Okay, welcome to lecture 6. This is the third and final lecture about anxiety disorders. And today we're going to be talking about generalized anxiety disorder in a lot of detail and also touching on separation anxiety disorder. And then this lecture is going to end with an overview of how anxiety disorders in general are treated, and also just some takeaways for anxiety overall. So we're going to start out today by talking about a new distinction that we haven't made before in this class between fear and distress disorders. Next, we'll talk about just what is GAD, and then about the function of worry as a maintenance factor for generalized anxiety disorder. A lot of this stuff goes a bit beyond what's in the textbook. So for this lecture for GAD, I would definitely focus your studying for this particular disorder on the lecture content. And if you have any questions, as always, feel free to ask for clarification. Next, we'll talk about what separation anxiety disorder is, and then we'll end with an overview of anxiety. So this image is something that we haven't looked at yet, but basically, one of our goals as psychologists is to try to understand how all of the disorders that we study relate to each other. Because even though we create these categorical diagnoses, we do believe that there are underlying dimensions to all of them. And some of these dimensions can be kind of higher level. So dimensions like internalizing and externalizing can help to explain how different disorders and their symptoms are related to each other. So internalizing and externalizing are two broad categories of disorder. And basically, they're distinguished by how symptoms manifest. With internalizing disorders, symptoms manifest in thoughts and emotions and internal experiences. Whereas with externalizing disorders, there are alterations in emotion and internal experience, but the main symptoms are external, behavioral. So a classic example of an externalizing disorder that's right here on this figure is antisocial personality disorder. So this is characterized by disturbances in emotion and social cognition, but mainly it's characterized by antisocial behavior, like criminality, manipulative behavior, interpersonal aggression. By contrast, specific phobia over here is an internalizing disorder because the disorder is not defined by how the person behaves, it's defined by how they feel around a phobic object. So in the beginning, in the first couple lectures of this class, and definitely so far, we've really focused on internalizing disorders. And specifically, so far, we've only talked about fear disorders. So like we've talked about a lot in the last lecture, panic disorder, social anxiety disorder, specific phobia are all characterized by inappropriate fear responses and anxiety about those fear responses in some cases. Specific phobia is all about having an inappropriate fear response to a conditioned stimulus, so like a phobic situation or object. Panic disorder is about anticipatory anxiety and avoidance around inappropriate fear responses that manifest as panic attacks. So intense feelings of fear that kind of come out of nowhere, that arise from internal bodily processes. And then social anxiety disorder has to do with anxiety about social situations, but the experience of acute anxiety and sometimes fear in those social situations. So by contrast, distress disorders are characterized not just by fear and anxiety, but by negative affect more broadly. And we'll talk more about what we mean when we say negative affect in the depression lecture coming up. But basically, affect is it just refers to our emotional state, and negative affect refers to things like anxiety and fear, but also sadness, guilt, and worry, which is something that we'll talk about a lot in today's lecture. And the disorder we're going to talk about in most detail today is generalized anxiety disorder. Even though it's considered an anxiety disorder, and it shares some of the biological and psychological risk factors with these fear disorders that we talked about in the last two lectures, it also has a lot of symptoms and processes in common with depression. So that's MDD, major depressive disorder, right here. And that is something that we'll talk a little bit about in today's lecture, but we'll definitely focus more on it in the next unit when we cover depression. So as a reminder, fear and anxiety really characterize the anxiety disorders that we've covered so far. So fear is an acute response. It's a physiological reaction that we experience emotionally as terror and dread, and behaviorally as a need to escape. So when it's adaptive, we feel fear in response to an immediate threat. So in our environment of evolutionary adaptation, this would be like being chased by a predator or being threatened by another person, something that is putting your life in immediate danger. By contrast, anxiety is more of a long-term future-oriented state, but it's still an emotion and it's still physiological. Anxiety is really just your body being ready to go into a fear response at a moment's notice. And when it's adaptive, we feel anxiety in a situation where danger is more likely. So there's no immediate danger or threat, but we know that we're in an environment where there are dangers present. So we're prepared to feel fear at any moment. And because fear has the adaptive function of helping us escape, anxiety has the adaptive function of helping us be prepared to escape when we're in danger. So in our environment of evolutionary adaptation, it would have been adaptive, it would have benefited our ancestors' survival to feel anxious when they were in, for example, the jungle, when they were out at night, when they were in a circumstance where there were predators around, but not necessarily predators threatening them immediately. So worry is a bit of a different animal than fear and anxiety, even though it's really closely related. We've seen this figure before. This is our anxious caveman ancestor who's not being threatened by a tiger right now, but he's thinking about threat and danger. So he's having thoughts and emotions that are consistent with being in an unsafe environment. Worry is, if anxiety is future-oriented, worry is even more abstract and future-oriented. If it's adaptive to feel anxious when we're in a dangerous situation, worry happens when we're in a safe situation, but we're thinking ahead to a time when we might be in a dangerous situation. So our anxious caveman who's safe at home in his cave might be thinking about going out hunting later and worrying about what would happen if a tiger ate him. So he has this thought about a potential future threat, not a likely future threat because he's not in a threatening situation right now, and not an immediate threat, which would make him feel fear because there's no tiger actively chasing him. But he's using his imagination and his human capacity for thinking about the future to think about how horrible it would be if a tiger did eat him. So starts with thinking about a potential future threat, and then kind of spirals into thinking about if the worst case scenario happened, if that threat came true, how bad would that be? Thinking about people he knows who've been eaten by tigers, thinking about how his loved ones would react if he got eaten by a tiger. And it ends with the adaptive function of worry. Thinking about the future and anticipating danger allows us to make plans. So he needs to go hunting, but maybe he'll take an extra spear, or maybe he'll ask someone to go with him. So worry in this case was part of his problem-solving process, thinking about future danger and figuring out ways to mitigate that danger or manage it. So that is the adaptive function of worry. It helps us plan ahead and it helps us anticipate and avoid danger. The definition of worry is a verbally mediated conscious process. And what that basically means is whereas anxiety and fear are very physiological, even though we do have a conscious experience of them, they start in the body. Worry starts in the brain, and then it can influence the body's state. Worry is also defined as a state of anxious apprehension. So when we're having worried thoughts, even though we're not in an environment where there's danger present, we might still feel anxiety because we're using our imagination to put ourselves in an environment where there's danger present. So generalized anxiety disorder, although it's an anxiety disorder where there is inappropriate anxiety, it's also characterized by excessive worry. And that makes GAD a little bit different from the other anxiety disorders we've talked about, where worry might be present, but the disorder itself is characterized and defined by anxiety and fear. So the criteria for generalized anxiety disorder are experiencing excessive anxiety and worry most of the time, so more days than not, for at least 6 months. So you don't get diagnosed with GAD if you just have a few weeks where you're really stressed out. GAD has to be a pretty prolonged experience in order for it to meet criteria for a diagnosis. People with generalized anxiety disorder worry a lot, and they feel like they can't control the worry. They feel like they can't stop worrying. They just can't control where their brain goes, and their brain tends to go to worries. GAD involves physical signs of anxiety and worry. So things like restlessness, muscle tension, difficulty concentrating, difficulty sleeping, irritability. And then, of course, like most disorders that we're going to talk about, you can't get diagnosed with GAD unless this worry and the associated physical symptoms cause impairment or distress. So in terms of prevalence, GAD is about as common as panic disorder. About 3% of people meet criteria for GAD in a year, each year. So that's the 1-year prevalence. And then the lifetime prevalence is about 6%. Unlike some of the other anxiety disorders that we've talked about, specifically specific phobia and social anxiety disorder, generalized anxiety disorder is less common in adolescents than it is in adults. Social anxiety disorder is actually more common in adolescence, which suggests that for many people it has an onset in adolescence, and for some people it goes away by adulthood. Specific phobia has an onset in childhood, and it tends to be really chronic. So the adolescent prevalence is similar to the adult prevalence because it has an early onset. GAD and panic disorder, on the other hand, both have an onset later in life. So panic disorder tends to have an onset in the early 20s. GAD tends to have an onset mid to late 20s, early 30s. But of course, like every anxiety disorder, onset can happen at any time. It's just less common in childhood. Like every anxiety disorder that we've talked about so far, generalized anxiety disorder doesn't really go away without treatment, so it's considered chronic. But unlike specific phobia, which is always present, people will always have a fear response to their phobic object, generalized anxiety disorder waxes and wanes. So people might go for periods of time where they don't meet the criteria for GAD, but then if they experience life stressors, that can cause the symptoms to come back. GAD is very responsive to stress. So even if someone continuously meets the criteria for GAD, their symptoms tend to get worse when they're stressed out, when they're dealing with problems in their life. So again, unlike other anxiety disorders we've talked about, where fear and anxiety is very stimulus specific, so it's linked to a certain physical sensation, a certain object or situation, or a certain place, or a category of places, that most people wouldn't fear because it's a conditioned stimulus for fear for the person suffering from the anxiety disorder. The things that people with GAD worry about, the things that make them feel anxious, are the same things that everybody worries about. And the only real difference is that people with GAD worry more about these things. They have a harder time stopping themselves from worrying, and they spend more time worrying. So people with GAD worry about health. They worry about their own health and that of their loved ones. They worry about their relationships, so maintaining their relationships, the health and safety of their family and friends. They worry about money, they worry about work, they worry just really broadly about the state of the world, global warming, the election, the economy, the pandemic. And again, these are things that all of us worry about. And the difference with GAD is really just a matter of degree. So we're all on that worry spectrum, and people with GAD are just at the far extreme. As I said, generalized anxiety disorder shares the biological and general psychological vulnerabilities with other anxiety disorders. So biological vulnerabilities, again, are just individual differences that influence someone's propensity to feel fear and anxiety. Psychological vulnerabilities, again, are people's beliefs about how dangerous the world is. So how threatening things like global warming and social relationships, and how likely it is that your loved ones will get hurt or sick. And then also how much control you have over the environment and over your own life. Whereas other anxiety disorders tend to start with a specific conditioning event or a series of conditioning events where a person experiences fear and anxiety that may or may not be caused by a stimulus, but that happens in the presence of a specific stimulus and becomes a conditioned association with that stimulus. Generalized anxiety is generalized. So it tends to develop through just sort of prolonged low-key stress that leads a person to become more sensitive to stress. So we talked about how chronic uncontrollable stress can sensitize someone's HPA axis. It can make your brain more likely to cause the cascade that results in the fight or flight response. And it can also inhibit the feedback mechanisms that cause that cascade to stop. So chronic stress can exacerbate a biological vulnerability, and it can also help to confirm negative beliefs about the world. So experiencing a lot of stress can confirm someone's belief that the world is dangerous and that they can't control stress. So whereas disorders that have a specific condition, fear stimulus, tend to have specific conditioning events, GAD can sometimes come on slowly. It can, because it's generalized, it's not tied to a specific life event or a specific situation. So it comes on gradually and through stress, but it's really maintained, like all anxiety disorders, by avoidance. And in this lecture, I'm going to argue that the type of avoidance that maintains anxiety in GAD is worry. So again, avoidance in the disorders that we talked about last time is often behavioral. So just staying away from places that you think it would be really bad to have a panic attack when you have agoraphobia. Avoiding things that would elevate your heart rate because that's a conditioned cue for panic. Avoiding difficult social interactions, or using safety signals to sort of mitigate and downregulate your own anxiety in the moment. Those are all kind of more obvious forms of avoidance, whereas avoidance in GAD is subtle and cognitive. But there are 5 basic processes through which worry, as a conscious, intentional process that we engage in, can help to manage and mitigate anxiety in a way that ultimately ends up maintaining it because it prevents habituation and safety learning. So the first is that people with generalized anxiety disorder often have positive beliefs about worry. And they're not completely wrong, because like most behaviors that humans universally engage in, worry does have an adaptive function. It probably served a survival purpose for our ancestors by helping them think about potential dangers they might face in the future and prepare for those dangers. The problem that people with GAD run into is when they think that worry is the only way they can solve their problems. And anytime they start to feel anxiety or tension, or that sort of physiological anxiety reaction, they believe that the only way that they can work through that anxiety and solve the problem that's causing the anxiety is by worrying. So looking at this example of the kind of worries that one of our evolutionary ancestors might have had about being eaten by a tiger. So we can all agree that it would be objectively bad to be eaten by a tiger, and I think we can all agree that it's good to think ahead to that situation and try to problem solve around it. What people with GAD and everybody else might differ on is whether it's necessary to have all of these anxious thoughts in the middle. So would our evolutionary ancestor have come to the same conclusion that he should take an extra spear and go hunting in a group if he hadn't scared and upset himself by thinking about people he knows who've died and how his family would react if he died? Probably, maybe, but people with GAD have the belief that if they don't worry, if they don't scare themselves, if they don't project themselves into the worst case future scenario and think about all the different ways that it could go wrong, then they won't solve their problems. And that's probably not true. So in GAD, worry is used in an attempt to manage and avoid anxiety. When people start to feel anxious, they start to worry in order to try to resolve the anxiety. Because again, worry is intentional. But when people worry, they tend to project themselves into the worst case future scenarios, and that actually just promotes anxiety. So even though it's an attempt to avoid by problem solving, worry really only exacerbates and maintains anxiety. So the key here to positive beliefs about worry is that people with GAD often believe that worry is the only way they can solve their problems. And our goal as therapists is to help them see that that's not true. So this is a sort of separate but related process. And this is actually the model of worry as avoidance that your textbook really emphasizes. So worry is avoidant coping. So worry is verbal. It's a conscious process that we engage in. It takes up a lot of our attention and focus. And the theory here is that when we engage in that worry process, it actually distracts us from the emotional, visceral, imaginal side of our anxiety. So when our ancestor is sort of thinking like, oh my God, it would be so bad if I got eaten by a tiger. Like, what would my parents do? How would my family feed themselves? Like, you would think that that anxiety-provoking thought process would lead to habituation, would help him kind of confront that feared situation by imagining it. But the reason he's not habituating to that, the reason he's not experiencing a peak in anxiety when he thinks about dying by tiger attack and then letting the anxiety come down, is because he's only thinking about it verbally. He's not actually letting himself feel the emotions that it brings up, and he's not using his imagination to visualize what it would be like. So he's really only doing half of the work of imagining that future outcome. He's creating low-level anxiety, but he's not actually experiencing the peak in fear and the habituation that would come from really vividly imagining that scenario. He's just kind of thinking around it. So worry prevents physiological habituation because although it's thinking about danger, it's preventing us from really feeling the emotions that we would feel if we used our whole imaginations to imagine that danger. So these are images of an fMRI of someone processing language. They're taken from the bottom, so like from the base of the skull upward, looking up to the top of the skull. So this activation here is actually on the left hemisphere, even though it looks like it's on the right of the screen. For most people, language is localized in the left hemisphere. So the thoughts that are happening in the right hemisphere of our brain are not verbally mediated. People who have split brain surgery, who have their whole corpus callosum severed, if they see something with just one eye, with just their right eye, sorry, which goes to the left brain, with just their left eye, which goes to the right brain, they know what that object is, but they can't verbalize it because language is processed in the left hemisphere. So people with generalized anxiety disorder, as your textbook says, have more activity in their left hemisphere than in their right hemisphere compared to other people without generalized anxiety disorder when they're told to worry, when they're told to think about an anxiety-provoking situation. So although everyone worries, people with GAD seem to be using language more than mental imagery when they worry. So the theory is that that is maintaining a low level of anxiety, what the textbook refers to as autonomic restriction, where people with generalized anxiety disorder, when they think about something that makes them anxious, they actually experience less sympathetic arousal, so less activation of the fight or flight system, less physiological evidence of fear and anxiety, compared to people with other anxiety disorders. So the theory is that because their worry is verbally mediated, it's actually preventing them from really experiencing the full range of anxiety and fear that the situations they're worrying about should evoke for them. And in addition to kind of using language and verbally mediated worry to suppress the emotional impact of thinking about scary situations, there's also evidence that people with generalized anxiety disorder have poor parasympathetic regulation of the sympathetic nervous system. So essentially, people with GAD get less acute peaks in activity of the sympathetic nervous system compared to people with other anxiety disorders, but they also experience less habituation. So their sympathetic nervous system is always a little bit activated. It doesn't go up and down the way that it's meant to, the way that it should when it's regulated properly by the parasympathetic nervous system. And both the left hemisphere dominance and autonomic restriction in GAD it sort of shows that the active process of worry might be blocking the unconscious physiological process of habituation. People who are worrying a lot are constantly thinking about danger, but they're not feeling the emotions that should come with those thoughts. And so they're not getting a chance to habituate to the anxiety that those thoughts bring. And I apologize for using this really old meme format, but this is basically the model of GAD that your textbook is using to explain the disorder. So a quote unquote healthy person, when they worry can be a strategy to process our emotions about scary situations in the future, but only if our verbally mediated thoughts about those feared scenarios are accompanied and balanced out by the experience of emotionally laden mental imagery. So left hemisphere and right hemisphere should both be equally activated when we're worrying. But in GAD, people focus so much on the verbally mediated thoughts that they're not attending to and they're not really experiencing habituation to the emotions that should come with those thoughts. I'm curious for your feedback if this meme helps you understand or makes you more confused. Okay, so the third way in which worry can function as an avoidance behavior is similar to positive beliefs about worry, but basically the idea here is that all of us feel uncomfortable with uncertainty. That's kind of a normal human way to feel. So it's another thing that's on a spectrum with most of us in the middle. But people with anxiety disorders are especially intolerant of uncertainty. People who are anxious really don't like not knowing exactly what's going to happen to them in the future. So for people with GAD, worry might be a tool for trying to relieve this anxiety and make the future feel more certain by actively trying to think up every possible scenario that could happen, to try to reduce the uncertainty about the future and reduce the anxiety that they feel about it. But of course, we can't actually predict everything that's going to happen in the future. And so what would be a more adaptive, healthy way of coping with anxiety about uncertainty would be to kind of lean into it and give ourselves a chance to habituate to the experience of anxiety about uncertainty. But intentional, conscious, verbally mediated worry in GAD prevents that from happening. Again, people are just sort of so busy thinking up all possible future scenarios that they never get a chance to actually learn that it's okay to feel uncertain about the future. They never habituate to uncertainty. They never experience safety learning where they tolerate uncertainty and things end up being okay. The uncertainty is resolved in a way that's not disastrous. So when people with GAD try to resolve uncertainty, they tend to think of the worst possible outcomes and kind of ignore the good outcomes or the neutral outcomes. And that's just because people with GAD are anxious. They have constantly elevated sympathetic nervous systems. Their parasympathetic nervous system is not good at calming down their sympathetic nervous system. So they're always anxious, and our thoughts, our conscious cognitive processes tend to be congruent with the way that we feel, with our emotions. So because people with GAD are always anxious, even though they're trying to resolve their anxiety by thinking about every possible thing that could happen in the future, because they're anxious, their thoughts are negative, so they only tend to think about the ways that things could go wrong in the future. Some people with GAD will have what we call magical thinking almost about the function of worry, where on some level, even though they don't necessarily believe that this is rational, they kind of believe that if they think of every possible negative outcome, every way that something could go wrong, it'll actually make those things less likely to happen. And the logic of that kind of goes like, well, if I imagine myself having a car accident on the way to work, like what would be the odds that the situation that I imagined and thought about would actually come true exactly the way that I imagined it? So they sort of feel like worry is protecting them from that bad thing happening, because it would be a huge coincidence if you imagined the specifics of a car accident and that image actually came true. Not everyone with GAD thinks that way, but it is sort of a common belief about anxiety that people can articulate, even though they realize that it's not rational. So the fourth way that worry can function as an avoidance behavior is also known as meta-worry, or worry about worry. So one of the features of worry in generalized anxiety disorder that makes it different from the worry that everybody engages in is that people experience it as difficult to control. But what if worry is difficult to control precisely because people with GAD try to control it? So people with GAD also tend to think that worry is bad for them. They think that it's physically or emotionally unhealthy, which they're not necessarily wrong about, because worry causes a lot of physical symptoms for them, or anxiety causes a lot of physical symptoms for them, and worry maintains anxiety. So although they're not wrong about it, the way that they go about trying to deal that is by consciously, actively trying to suppress their worries. So this kind of seems like it goes against the other models of worry, where people intentionally use worry as a coping mechanism or as a distraction, or try to come up with every possible way that things could go wrong to try to plan ahead for that, or to try to make it magically less likely that that will happen. But those same people can also kind of feel ambivalent about the function of worry. They might kind of know that they use worry in ways that are not healthy or maladaptive, and so sometimes use worry to problem solve, and sometimes feel like, you know what, no, this is really bad, this is really unhealthy, I need to stop these worries, I need to stop having these intrusive thoughts, these thoughts are bad for me, I have to shut it down. So it's kind of, both of these things can be happening in the same person, and it causes a lot of like tension and conflict. But meta worry, so worry about the implications of worry, can sometimes lead people to try to effortfully suppress their intrusive thoughts. And this is an example from the show The Good Place. these are not spoilers, but the characters here are in heaven. And this character, Chidi, is sort of grappling with the fact that even though he's in heaven in the afterlife, he still has all these worries and anxiety. And he's really worried about the implications of that. Like, how can I still be worried even though I'm in a perfect utopia? So it's not just that he's worried, but he's also worrying about the implications of worry on top of that. Okay, so this is kind of a demonstration of what makes worry seem uncontrollable for people with GAD. So I'm gonna just challenge you for the next 60 minutes, and it's gonna feel like a really long time, but really do try this. For the next, sorry, not 60 minutes, for the next 60 seconds, try really hard not to think about a white bear. So like this, don't think about this. Think about anything else that you wanna think about. Think about different colors of bear, black bears, brown bears, whatever you want. Don't think about white bears. Use whatever strategies you can to try to keep thoughts about white bears from entering your head. And if thoughts about white bears do enter your head, do what you can to get rid of them as soon as possible. So do this for the next 60 seconds. I'm gonna time it. Starting now, don't think about a white bear. Okay, 30 more seconds. Keep suppressing those thoughts. Fifteen more seconds. Okay, you can stop suppressing. So were you successful? Were you successfully able to totally block thoughts about white bears? Were you able to not think about that thing that you were trying not to think about? And whether or not you were successful during the 60 seconds, what was the first thing that you thought about when I said that you could stop trying to suppress? Probably for some of you, a good number of you, thoughts about a white bear kind of continued to creep in, even though you tried to stop them and suppress them every time they came up. And also for some of you, as soon as you stopped actively trying to suppress those thoughts, thoughts about white bears probably popped into your head. So this demonstration comes from a famous experiment in psychology known as the white bear experiment, where participants were actually told to spend 5 minutes trying not to think about a white bear. And they were asked to ring a bell every time that they did have a white bear thought. So on average, people who were actively trying to suppress these thoughts had them about every 60 seconds. So I would say that they were fairly successful, right? Like they didn't spend the entire 5 minutes thinking about a white bear. They were able to suppress most of the time. But even though they were trying to suppress, the thoughts came back up. So next, after that, the same people who were told to suppress thoughts about a white bear, not think about it, were told that now they should think about a white bear for 5 minutes. And now a control group came in who hadn't previously been told to suppress thoughts about a white bear. And that control group were just only told to think about a white bear. So we have two groups of participants now actively trying to think about a white bear. People who suppressed white bear thoughts for 5 minutes before, and people who had never had to suppress white bear thoughts. So what this demonstrated was rebound effects. Participants who were told not to think about a white bear ended up having more white bear thoughts when they were allowed to think about it than a control group who had never suppressed those thoughts. So this is just a demonstration that suppressing your thoughts doesn't work. And if anything, it can lead to those thoughts coming up more. And it leads to the perception that worry is uncontrollable because you're trying really hard not to have these thoughts. That makes it more likely that you will have those thoughts as soon as you stop trying. So it makes the act of suppressing worry feel really necessary because you have all these meta worries about the implications of it, but really difficult because it's very hard to suppress our thoughts, even when we're consciously trying. And as soon as we stop consciously trying, we have this rebound effect. So the last potential function of worry as an avoidance behavior is contrast avoidance. So we know that generalized anxiety disorder as a specific psychological risk factor involves heightened sensitivity to stress. So people with GAD are more prone to experience anxiety and negative affect in response to stress than other people. As a general psychological belief, people with GAD, or risk factor rather, people with GAD expect that the world is dangerous and they expect that they won't be able to control their environment, that they won't be able to control that danger. So they have these underlying beliefs and they have this heightened responsiveness to stress. So to some extent, the beliefs are grounded in reality because their response to stress is stronger than other people's. So we already know from the textbook that GAD involves the experience of autonomic restriction, where even though they never experience peaks in sympathetic arousal, they don't experience fear and panic as much as people with panic disorder. They also don't experience relief from sympathetic arousal. Their sympathetic nervous system is always activated at a low level, and their parasympathetic nervous system is not downregulating it the way that it should. So a question that you might have as we talk about worry as a way of avoiding anxiety is that, why do people keep doing it if it doesn't work? People with GAD are always anxious, so how does worry actually function as an avoidance behavior? Especially since there is evidence from psychophysiological studies that when people worry, whether or not they have GAD, they experience greater sympathetic activation. So if people with GAD are always anxious, then what is it that worry is really helping them to avoid? So, whoops. This is an experimental demonstration of the principle of contrast avoidance. So people with generalized anxiety disorder were randomized to either intentionally worry or to try to relax. And they did this for about 5 to 10 minutes before an experimental manipulation. So next, after either worrying or relaxing, both groups were shown a scary movie clip. And then both groups were asked to report their level of fear in response to the worry clip. So what we can see here is that people who intentionally tried to relax, this is known as the induction, so the induction of either worry or relaxation. People who relaxed were experiencing lower fear and anxiety before the film clip compared to people who worried. So worry raises people's fear and anxiety levels. But the important thing about this study is that for people who relaxed prior to seeing the film clip, they experienced a big increase in fear and anxiety in response to this environmental stressor, which was experimentally manipulated in this case, but it's meant to represent real stress that can happen in people's lives. So people with GAD who relaxed first experienced a huge increase in anxiety and fear in response to a stressor, whereas people with GAD who worried first didn't experience a major increase. They didn't experience a statistically significant increase in worry and fear. They were already worried and afraid before that stressor happened. They were kind of prepared for it. When the stressor happened, they were already stressed out, so they didn't experience a big increase in stress. So the theory here is that worry doesn't work to avoid anxiety in general. Worry actually increases anxiety, and attempting to suppress worried thoughts doesn't work. But what worry does do is it prevents us from experiencing huge emotional shifts. When we're worried all the time and something stressful happens, that helps to prevent the experience of big sympathetic swings, so big increases in sympathetic arousal. And people with GAD are just more sensitive to those increases in sympathetic arousal. They don't tolerate them, they don't like them, and they worry as a way to prevent them from happening. So even though this is not necessarily a conscious process, the thought process, if it was conscious, might go something like, I really don't like surprises. I really don't want to go from like 0 to 60 if something stressful happens. I'd rather be prepared. I'd rather always be running at 30. So then if something stressful happens, I'm already worried and upset. So the change in my mood won't be that drastic. So the idea is that people with GAD aren't necessarily motivated to avoid anxiety because they're always anxious. What they're trying to avoid with worry is big changes in their emotional state. So in summary, we talked about 5 ways that worry can function as an avoidance behavior. So I'm gonna kind of challenge you to try to match these verbalizations of each of these 5 functions of worry to the way that worry can function as an avoidance behavior. And it's important to remember that even though some of these things seem contradictory, especially thought suppression and all of the other ones, people can engage in contradictory emotional regulation strategies. And in fact, people who are prone to meta worry, people who are prone to worry about worry, would worry about that too. So someone who engages in thought suppression and feels like worry is bad for them, they might still use worry as avoidant coping. They might still use worry to distract themselves from fear and emotional imagery in their right brain, but they'll just feel bad about that and they'll worry about the implications of doing that, and that will just add to their worry burden. So they might try to suppress worry sometimes. Sometimes they might give up on trying to suppress worry and use worry in these other ways to try to manage their anxiety. But the important takeaway is that all of these uses of worry, anytime someone is using worry as a conscious process to try to manage or mitigate their anxiety, that's an avoidance behavior, and avoidance maintains anxiety. So in terms of treatment for generalized anxiety disorder, there are medication treatments, and we'll talk about that in a few slides. But psychological treatments for GAD include things like mindfulness and meditation. So this really targets thought suppression, because thought suppression is all about trying to control your thoughts, trying to prevent yourself from having certain thoughts that you think are bad. Whereas mindfulness is all about just kind of letting your thoughts come and go and not really engaging with them at all. Mindfulness can also work against the other strategies, other avoidance strategies that use worry. So if you kind of accept that uncertainty will happen and you'll have to deal with it when it comes, via mindfulness and meditation, you'd be less likely to try to use worry as a way of mitigating uncertainty and trying to think of every possible outcome. There are exposure-based treatments for GAD that involve vivid imaginal exposure to not just the thoughts that people have about a feared outcome or a situation that causes them worry, but the actual emotions and imagery that come with that situation. So if someone spends a lot of time worrying about like their partner's health status, a therapist would encourage them, rather than just thinking like, oh my God, what if that weird cough they have is COVID? Like they don't sleep very well. What if their sleep apnea leads to cognitive decline? What if they get dementia when they're older? Rather than just letting them focus on that level and having all those worried thoughts, a therapist might encourage them to go a little bit deeper and say, okay, so you're worried that they might have dementia when they're older. Let's really think about what that would be like. Like, let's think about what it would feel like if they forgot your name. Let's think about what it would be like to be a caregiver for them, always like, you know, having to feed them and take care of their hygiene and having them not know who you are. Like, rather than just thinking about how bad that would be, let's really try to feel it. Let's feel the sadness and the anxiety that comes with that image. Another strategy that also kind of functions as an exposure is limiting worry. So this is really for people who use worry as a problem-solving tactic or who consciously use worry to try to mitigate fear of uncertainty. A therapist might say, okay, so you think you need to worry to solve your problems, that's fine, but you don't need to worry all the time. So set aside an hour a day to really sit and worry and think through all your problems and think about all those worst case scenarios, but limit it to that. Once you're done with that 60 minutes of worry, when worries pop into your head, don't try to suppress them, but remind yourself, no, wait, I already solved that problem. I don't need to have this worry. I can do something else now. And then the last thing is cognitive restructuring, which involves directly challenging the content of worry, and specifically challenging the assumptions that underlie the worry, which therapists call cognitive distortions. So the goal is to replace worry thoughts, which tend to be congruent with anxiety, and so they tend to be pretty negative, to try to replace those negative, anxious, unrealistic thoughts with thoughts that are more balanced and realistic. So using the example of someone worrying about their partner's health, instead of kind of focusing on all the negative things that could happen, like, oh my God, what if their sleep apnea leads to cognitive decline because there's a relationship between those two things? Think about more realistic, more controllable outcomes. So like, okay, they don't sleep very well. Maybe I should try to make an appointment with them at the sleep clinic. Like, rather than worry about all the bad things that could happen, what about the situation is within my control? And also, how likely is it that their sleep difficulties will lead to cognitive decline when they're older? Like, it's possible, but it's not a sure thing the way that my anxiety is making me think it is. So we'll talk a little bit more about cognitive distortions and about exposure for generalized anxiety disorder and anxiety in general in a few slides. Sorry, my nose is so itchy. I think I might be allergic to something. But first, we're going to talk about separation anxiety disorder. Okay. So separation anxiety disorder, the reason we're talking about it in this lecture is that in a lot of ways, it's very similar to GAD. It involves unrealistic and persistent worry. So it's a worry-mediated disorder. That something will happen to the person themselves or to their loved ones when they're apart from their loved ones. The worries tend to be kind of unrealistic and excessive. So they worry about their loved one being kidnapped, someone breaking into the house when they're home alone, their loved one getting into an accident. They might also worry about their loved one, like if it's a romantic partner, leaving them or abandoning them. So people with separation anxiety disorder have all these worries about what might happen when they're separated, and that leads to anxiety about separation. So trying to avoid separation or feeling really anxious when separation happens. So separation anxiety disorder used to be thought of as a disorder that only happens in childhood, because in childhood, separation anxiety is actually very common. Just like how we talked about with selective mutism last time, mutism is not common in children, but silence and shyness are common in certain situations. So for young children, separation anxiety is really common. But what researchers found when they applied the criteria for separation anxiety disorder to adults is that it's actually more common in adults than it is in children. And that probably has something to do with the fact that there's a lot of comorbidity between separation anxiety and other psychological conditions. So somewhere between 20 and 70% of people, adults with separation anxiety disorder, have another mental health condition. They also often have a physical health condition. So people with separation anxiety disorder tend to worry about separation specifically from a loved one who has kind of a caregiver role. Someone who either helps them directly, so helps them manage a health condition, or is like their safety person for agoraphobia, helps them leave the house and feel safe, or just takes care of them indirectly, so helps them to regulate their emotions by talking to them when they're worried, or helps them to get through a panic attack. So both separation anxiety disorder and generalized anxiety disorder involve persistent worry. So in that way, they're similar. But worry and generalized anxiety disorder is not limited to one topic. So people with GAD might have separation worries, but they also have a whole bunch of other worries. Worries in generalized anxiety disorder tend to be realistic. So whereas someone with GAD might worry about their loved one getting into an accident, like a car accident, or they might worry about their long-term health, they'd be less likely to worry about something extreme like their loved one being kidnapped when they go to the grocery store. That type of worry content would be more associated with separation anxiety disorder. Although that isn't to say that people with separation anxiety disorder can't also have more realistic worries. It's the main difference is more that the worry in separation anxiety disorder is focused on the consequences of separation from a loved one, whereas in GAD, the worry is a lot broader and focuses on the same topics that everyone worries about. So like I said in the last slide, people with separation anxiety disorder tend to worry about being separated from a caregiver, either someone who actively functions as a caregiver or someone who the person relies on to help manage their anxiety or their mental health symptoms. So one specific risk factor for separation anxiety disorder has to do with adult attachment. So in the further readings at the end of this slide set, there's a link to an adult attachment style questionnaire that you can take to kind of get a sense of what your attachment style might be. But basically attachment is divided into 4 quadrants. So along one axis, we have anxiety. So the level of anxiety someone experiences in their relationship. And then on the other quadrant, we have relationship avoidance. So how much people either seek out close relationships or avoid them. Someone with secure attachment, which is about 55% of adults, have both low relationship avoidance and low relationship anxiety. They seek out relationships, but being in a relationship doesn't make them anxious. It makes them feel good. It makes them feel mostly positive emotions. Someone with high relationship anxiety, but low relationship avoidance would seek out relationships, but would tend to ask for a lot of support in those relationships and tend to have a lot of worries about losing those relationships. So this is also known as anxious or preoccupied attachment. And it's a risk factor for separation anxiety disorder. So adults with separation anxiety disorder are more likely to have this attachment style. where they want to be in a relationship, but they experience a lot of anxiety about losing the relationship once they're in it. So people with this attachment style tend to be fearful of abandonment, and they tend to seek a lot of reassurance from their loved ones that they won't abandon them, either by intentionally leaving and breaking up with them or by having an accident and dying. Another suggested reading is a Wall Street Journal article that there's a PDF of in the Google Drive folder and on Canvas. The article is called "When It Never Gets Easier to Say Goodbye," and it profiles two adults with separation anxiety. The first one is a middle-aged man who has separation anxiety from his wife, and the article describes his reaction to her going on a cruise for a couple of weeks with her friends. So he's really clingy as she's getting ready to go, to an extent that's really annoying and causes arguments. And then once the separation happens, he experiences a ton of worry accompanied by physical symptoms similar to GAD, like loss of sleep. And some of the worried thoughts he has are things like, she'll have a car accident, she'll get sick, she'll get hurt, she'll leave me for somebody else. And this person has insight, so he can say, like, I know that my worry is not realistic, but I'm just so scared. Like, the idea of losing this person that I love is so scary that the only way I can deal with it is to worry. The other person profiled has separation anxiety from her teenage and adult children. So one way that she copes with her worry is to save voice messages from her kids, which a lot of people do, but they don't always do it because they want to have their voice recorded in case they die. People with separation anxiety spend a lot of time worrying about their loved ones dying and how they'll cope with it. Like people with GAD, though, those worries are verbally mediated, and those worries might function to kind of prevent the person from actually letting themselves feel the emotions that would be associated with losing their loved ones. They're just kind of planning ahead and worrying about how they'll deal with it. She also engages in other kinds of avoidance, like making sure she always has her phone on her so that she can get bad news right away. And she experiences a lot of anxiety when her phone rings because she always anticipates the worst. Every time her phone rings, she thinks it's going to be news that one of her children is dead. Okay, we're getting close to the end. Oh my God, I'm so sorry, my nose is so itchy. Okay, so we're going to talk about anxiety disorder treatment more broadly. We talked a little bit about some GAD specific interventions, but overall, anxiety treatment has two key components and then one sort of optional component. So all anxiety treatment, all effective treatment for anxiety involves exposure because all anxiety is maintained by avoidance. This cycle illustrates what maintains anxiety over time. People with any kind of anxiety disorder have a belief or an expectation that they can't cope with the anxiety that is caused by their feared situation or object, or the anxiety that comes with negative thoughts about the future. So rather than sit with that anxiety and experience its peak, because people with anxiety disorders often believe that if they don't escape from the anxiety, it will never peak. It'll just keep climbing and climbing until they can't bear it anymore. They will find some way to avoid. So people with panic disorder and agoraphobia might use safety signals to try to avoid. So they'll seek out an object that's been associated in the past with an escape from anxiety, like someone with emetophobia drinking mint tea or CBD oil. They might avoid phobic objects altogether. So if they are walking down the street and encounter a dog, when they have a dog phobia, they would avoid peaking anxiety by crossing the street and getting away from the dog. With someone with GAD or separation anxiety, the anxiety that they kind of try to avoid and feel like they couldn't bear is not just the anxiety, but just all of the negative emotions that would come up for them if the things that they worried about really happened. So for someone who worries about her adult children dying, rather than really let herself feel the emotions that she might feel in that situation, all the sadness and anxiety and fear that comes with those thoughts, she just focuses on the thoughts, and she creates an environment where she feels like she can manage those thoughts by like having her phone on her at all times so that she'll know right away if the worst does happen. And so that because the worst isn't happening right now, she can tell herself, nobody's calling me to say that my children are dead, therefore they're alive, and I don't have to think about how bad it would be if they did die. So exposure works through habituation and safety learning. So avoidance prevents both of those things from happening. If you escape from your anxiety before it reaches its peak, you don't give your parasympathetic nervous system a chance to do its job and downregulate your sympathetic nervous system. And you don't give yourself the chance to learn through conditioned associations that you can be calm and you can experience parasympathetic activation and downregulation in the presence of the stimulus that causes anxiety, in the presence of the conditioned stimulus. You also don't experience safety learning. So you don't learn that the situation that you escaped from isn't actually dangerous. You don't learn that having awkward pauses in the conversation or wearing your shirt inside out isn't as humiliating and scary as you predicted it would be if you never let those things happen to you. So treatment for every anxiety disorder really hinges on exposure and eliminating avoidance. The form that exposure takes can vary from disorder to disorder, and it really depends on what avoidance looks like in that population. So exposure for something like specific phobia or selective mutism, where there's a specific fear of one object or situation that the person just always avoids, exposure for that is really concrete. It's instead of avoiding that specific thing or that specific act, we're going to do it, and you're going to experience habituation from doing it. So if you think back to the video of the woman going through exposure therapy for a cockroach phobia, for her, exposure just involved being around cockroaches in increasingly intense ways and allowing herself to habituate each time. For the adult man with selective mutism, exposure involved talking, essentially, but again, in sort of a systematic way, starting with talking in easier circumstances and working his way up to talking in harder ones. For panic and agoraphobia, exposures are interoceptive. So people who have panic attacks have conditioned fear of their own physical sensations. Things like elevated heart rate, difficulty breathing. Many people with panic disorder have trouble wearing masks because that feeling of slight difficulty breathing can mimic some of the early signs of a panic attack and hyperventilation. So for someone with panic disorder, going around in a mask, maybe exercising in a mask, so experiencing that kind of interoceptive feeling of difficulty breathing in the absence of an actual panic attack. So exposure to that conditioned cue in the absence of real anxiety is a form of exposure. For someone with social anxiety disorder, in addition to just exposing themselves to increasingly difficult and feared social situations, they would also kind of set these things up as experiments. So the goal would be to see what is my feared outcome, what's the worst thing that could happen from this social situation? And if I do it, what actually happens? Does my worst fear come true? If it does, was it as bad as I thought? Or does it not come true, and what happens instead? So with social anxiety disorder, exposures are really set up as social experiments. And then lastly, with GAD, because people with GAD don't have specific fears of specific objects or situations, exposure really has to do with eliminating the function of worry as avoidance. So worry prevents people with GAD from experiencing vivid mental imagery of the things that they worry about. So exposure would look like getting someone to try to have a vivid emotional experience associated with something that they worry about. Like the example with someone who worries about their partner's health, instead of worrying and thinking about how bad it would be if they had dementia, really trying to have an emotional experience, really try to project their emotions into that future that they worry about. And instead of just having the thought, like, it would be so bad if they forgot my name, instead trying to use their imagination to actually feel the emotions that they would feel, the emotions that the worry thought is preventing them from experiencing. And what they would learn from that is that it feels really bad to have those emotions, but they can tolerate it, they can live with it. They don't have to avoid those emotions through worry. They can just let those emotions happen. And like all emotions, like fear and anxiety, the emotions that they're trying to avoid are short-lived. They're not going to feel that way forever. So rather than worry and try to keep those emotions in check, but kind of constantly present at a low level, they can let those emotions peak and then come down. And similarly, people with GAD often benefit from exposure to emotional contrasts. So actually encouraging them to relax first and then try to elevate their emotions. So first relax and then put yourself in a stressful situation, or then have vivid mental imagery of your feared outcome happening, to again prove that the thing that they're using worry to avoid isn't actually that bad, and they can tolerate that thing without avoiding it through worry. Oops, I think I have a double slide in here. Okay, so this slide is really complicated, and this could really be its own class. So this is just kind of like a very rough overview to what cognitive restructuring is. So basically, cognitive restructuring has to do with recognizing logical inconsistencies or errors in thinking associated with anxiety. And we also call these things thinking traps. So this is a whole list of examples and definitions of different thinking traps. It's not exhaustive, and the terminology can kind of vary from therapist to therapist and sometimes from disorder to disorder. But some of the most common thinking traps that come up with anxiety disorders are catastrophizing. So always envisioning the worst case scenario, always expecting the worst thing to happen. So with panic disorder and agoraphobia, this might be, if I have a panic attack while I'm driving, I'll crash the car and die. That's catastrophizing. That's the worst thing that could happen if you have a panic attack while you're driving, but not necessarily the most likely thing. With GAD, catastrophizing could take the form of, if my partner doesn't deal with their sleep apnea, if they don't wear their CPAP every night, they will definitely get dementia when they're older, because poor sleep will cause dementia. With challenging the logic of a thought like that, you would actually ask them to think, like, how likely is it that that would really happen? It's not to say that it's impossible. Like, there is a connection between poor sleep and cognitive functioning, but it's not the one-to-one relationship that you're thinking it is, that you tend to predict when you're feeling really anxious. So catastrophizing is expecting the worst. And when you challenge catastrophizing, you ask people to actually reason about how likely it is that the very worst thing will happen. Mind reading is a common distortion that comes up in social anxiety disorder especially, but also in panic disorder and agoraphobia. So this is when you think that you know what other people are thinking. And with social anxiety disorder, it's really when you think that you know what other people are thinking about you. When you know exactly how anxious you are, and you sort of make the mistake of thinking that other people know that too. What's really obvious to you isn't always so obvious to other people. And when you challenge mind reading errors, you really ask people to reason about, how likely is it that other people actually are thinking this? How likely is it that something that I know is happening because I'm experiencing it is as obvious to other people as it is to me? Where mind reading might come up with panic disorder and agoraphobia is someone thinking like, I absolutely can't take the risk of having a panic attack at work because everyone would know that it was happening and people would judge me. Well, you could ask them to challenge that by thinking like, how likely is it that people would actually be able to tell that you are having a panic attack? Like, it's really obvious to you, but is it really that obvious when you're to an observer who doesn't know that you have panic disorder, that you are having a panic attack? And then if people did realize that you were having a panic attack, then what? Why do you assume that they would judge it negatively? What else could they think? Like, what other judgments could they make? With something like separation anxiety disorder, mind reading thoughts could be like, oh my God, I'm being so clingy. I'm asking for so much reassurance. My partner is going to get sick of me and dump me because I'm so annoying. Well, you don't know that. You can reason about the likelihood of that, but when you're really anxious and you have that thought, it seems like a sure thing. So overgeneralization is a common thinking error in GAD, where people think that because something bad happened, it means that the next thing will be bad too. Like when you fail a test, overgeneralization would lead you to feel very certain that that failure means that the next thing that you try will be a failure too. And with overgeneralization, you just try to get people to ask, does this one bad event, does this one piece of bad luck or this one failure on my part really mean that the next thing I try is going to be a failure? Maybe the next thing is totally unrelated. Maybe the thing I failed at was like something athletic or pledging a sorority and not getting in. Overgeneralization might lead me to think that I'm just a failure overall, and so I'm going to also get bad grades this semester. Well, those things don't really have anything to do with each other. the only thing that could connect them is luck, and there's really no such thing as bad luck. So you can challenge overgeneralization in that way. But if someone's overgeneralizing between events that could be causally related, so I failed my first midterm, so I'm definitely just going to fail this whole class. Well, you can ask, like, do you have any control over that chain of events? Like, is there anything that you could do to prevent yourself from failing the next class? Or is it just a sure thing because you've already failed this test? And then the last common thinking error that comes up with anxiety disorders is emotional reasoning. And this is a big one in GAD. So like we talked about with intolerance of uncertainty and worry as a coping mechanism for that, when you're feeling physiologically anxious, your thoughts tend to be congruent with that. So if you're feeling anxious, the content of your thoughts tends to be anxious. But with emotional reasoning, people tend to take their emotions as evidence for the truth. So if you have a thought and you're already feeling anxious, that makes that thought feel more real if you think about something bad happening. So it's important to remind people, when you're thinking about your mom getting into a car accident and feeling really anxious about it, that anxiety is causing the thought, not the other way around. You're having anxious thoughts because you're feeling anxious. You're not feeling anxious because those thoughts are likely to come true. Okay, we're getting close to the end. Oh my gosh. I need to take a Benadryl or something. Okay. So a lot of you guys have asked on the discussion board about pharmacotherapy for anxiety. The textbook talks about benzodiazepines and says that they're currently one of the most common treatments for anxiety disorders. The way that those work, these are Xanax bars. Xanax is a commonly prescribed benzodiazepine. The way that benzodiazepines work is they're GABA agonists, so they work very similarly to alcohol. They kind of turn down anxiety in your whole brain. They reduce the physiological and cognitive impact of anxiety, and they make it less likely that while that drug is in your system, you'll feel anxious. So it raises your threshold for feeling anxious. It would take a lot more to make you feel anxious when you have benzos in your system. So benzos are really fast acting. The woman with panic disorder and agoraphobia was saying that when she went to the hospital with a panic attack, she was prescribed benzodiazepines to try to calm her down and end her panic attack. And those drugs really are super effective for that. They end anxiety responses really quickly, and they prevent them from happening as long as the drug is in someone's system. Beta blockers are similar, but instead of reducing both physiological and cognitive anxiety, they really only reduce physiological arousal. So beta blockers are really effective for people with performance anxiety because they eliminate the negative impact of anxiety on complex motor tasks and motor performance, but they don't impact cognitive anxiety. And they also don't have the effect of alcohol and benzodiazepines of making you less good at fine motor skills. So someone who's like a professional violinist or a professional athlete wouldn't want to take Xanax before performing, because even though it might make them feel less anxious, it would also negatively impact their performance. So someone like that might take beta blockers instead. The third treatment for anxiety, and the one that's becoming increasingly common and accepted in the field, is SSRIs. So selective serotonin reuptake inhibitors were initially developed to treat depression, but they also have effects on anxiety, although you need higher doses for them to be efficacious against anxiety. Whereas the effect of benzodiazepines and beta blockers are both immediate but short-lived. They only have an effect as long as the drug is in your system. The effect of SSRIs takes a while to come online, usually a couple weeks, but it has long-term efficacy. And we actually don't really know why SSRIs work to reduce anxiety. They could just sort of tune down overall negative affect, and anxiety and depression are frequently comorbid. So by reducing depression and negative affect, they could also have a beneficial impact on anxiety by just making a person feel better overall. But there's also some evidence that that SSRIs enhance neuroplasticity. So they promote regeneration and growth of new cells, which can promote learning. So anxiety treatment is all about learning. It's about habituation, which is a form of learning, and the development of a new conditioned association, and safety learning, which is cognitive learning. So it's possible that SSRIs work to enhance the effect of exposure and promote the learning that happens when someone avoids less. So in terms of efficacy, sorry, cat's eating my plant. In terms of efficacy, it depends on the disorder. So for specific phobia and panic disorder, and for performance anxiety, so non-generalized social anxiety, CBT, so cognitive behavioral therapy that emphasizes exposure, is better than medications alone. Sorry, this should just be greater than, not greater than or equal to, because the combination of CBT and medications is just as effective as CBT alone, and either one of them is better than medications alone. But, oh, I'm sorry. I got confused. That should be greater than or equal to, because in the short term, medications alone can be effective, but in the long term, medications alone are not as effective for those disorders, for the very specific fear disorders. For generalized social anxiety, or sorry, yes, generalized social anxiety and generalized anxiety disorder, there is evidence that combined therapy, so CBT plus medications, is more effective than CBT alone. But in the long term, again, any treatment that involves cognitive behavioral therapy with or without medications is more effective than medications alone. So one thing that I want you guys to think about on the discussion board, and that we'll talk about in class, is why don't medications have better long-term efficacy? And why might some medications like benzodiazepines and even beta blockers be contraindicated for long-term benefits? Okay, so this is the last slide. So some overall takeaways, first from this lecture. The biggest thing to think about from this lecture is that even though it can seem counterintuitive, worry is an avoidance behavior in generalized anxiety disorder. Just because something is an avoidance behavior doesn't mean it works. It doesn't mean it works perfectly. All avoidance behavior maintains anxiety. So in GAD, worry functions to maintain low-level chronic anxiety, but it kind of prevents the experience of like sudden sharp increases in anxiety. It prevents anxiety from ever peaking. And it makes it less likely that someone with GAD will experience really acute fear because they're constantly maintaining themselves at a moderate anxiety level that to them, they perceive as tolerable. Separation anxiety disorder is very similar to generalized anxiety disorder. And really the main difference is that the worry is only about separation, only about harm coming to the person themselves or their loved one during a separation. But worry probably has the same function in separation anxiety disorder that it does in GAD. And both of those disorders are more on the distress side of the spectrum versus the fear side of the spectrum. So important processes to think about in overall for anxiety disorders are anxiety, fear, disgust, and worry. So think about what each of those things is, how they differ from each other in terms of physiological processes and response tendencies, so the behavior that is associated with them. Also think about the differences in the extent to which they're physiologically mediated or cognitively mediated. Another important thing for all anxiety disorders is that there are general risk factors, both biological and psychological, that predispose someone to develop any anxiety disorder. The specific anxiety disorder that someone develops depends on more proximal specific psychological risk factors, which typically are environmental stressors in the context of generalized risk factors. The environmental stressors don't always have to be real in the environment. Sometimes it can just be having an uncued panic attack in the presence of something that becomes a conditioned stimulus for anxiety. Another thing to think about is that the environment, especially the early childhood environment, modifies both biological and psychological general risk factors. And then lastly, the absolute most important thing to remember about anxiety is that it's maintained by avoidance, because avoidance prevents habituation and safety learning. So when we treat anxiety, we need to make sure that habituation and safety learning are happening. And we do that by ending avoidance. So here are some further readings from this lecture. And that is that. I will see you in class on Tuesday and Thursday.